dermatologists and psychiatrists, and the purpose of my presentation is to raise questions about the importance of the inflammations in health and disease. I'm convinced that inflammation plays a crucial role in the development of mental diseases. So, do physical and mental illnesses really exist? We progress from a Cartesian dualism to an integrated perspective of our patients. And now, neuroscience led us back to a monistic view. And what is a monistic view? Spinoza was a philosopher in the 17th century who opposed Descartes, placing human being as part of the whole nature. For him, body and mind were not separate, they were expressions of the same reality. Inflammation is a key concept in understanding transdiagnosis phenomena, and depressive syndrome is the most frequently mental disorder associated with skin diseases. And we understand the syndrome as a complex of symptoms with different possible etiologies. So, depression syndrome is truly a comorbidity. I think it's not a comorbidity. I think it's rather another expression of the inflammation itself. Remember that cytokines can produce depression by itself. And another question could be, is bipolar disorder an inflammatory disease? Bipolar disorder is a biological, chronic, and episodic disease characterized by different symptoms like depression, euphoria, it can present mania, hypomania, and it can present mixed episodes too. And these mixed episodes, I think, are very important for us because they occur with a severe symptom, depression symptoms, plus irritability and impulsivity. And this situation predisposes patients to commit suicide, and some medications can trigger these episodes. For example, the antidepressives, antibiotics, and different medications. And this disease is frequently misdiagnosed. It's usually confused with depression, with major depression, and it's linked with inflammatory skin diseases. And it can be found high levels of cytokines in patients with bipolar disorder. These are different systemic diseases related to bipolar disorder. And another question is suicidality related to inflammation? Suicidality encompasses different steps from suicidal ideation, suicidal planification, suicidal attempts, and commit suicide. And it's important because inflammation could be another big factor for the suicidality. They have been found CPR levels, high CPR levels associated with patients with suicidal behaviors. And there have been found high levels of interleukin, 6 interleukin, in cerebrospinal liquid in patients who have committed suicide. So can some medication affect mood and predispose to depression and suicide? And in this case, why? In this case, for example, corticosteroids, which usually produce euphoria, insomnia, but in a part of the group of patients, can produce hypomania, mania, and depression. And it's related with dysfunction in the HPA axis and in the hippocampus area. About retinoids, while in the psychiatric literature, usually it's demonstrated that the existence of a clear association with depression, psychosis, and suicidal behavior in patients who use isotretinoin. In dermatological literature, it's remained not confirmed. So, the mechanisms, or the neurobiological mechanisms, why this medication can produce this, is related to changes in neuroplasticity, changes in the orbital frontal complex, and with elevated corticotrophin in hippocampus. It has been found that patients with bipolar disorder had more risk to have psychiatric adverse effects when they use isotretinoin. And Dr. Brennan in 2022 showed that the isotretinoin has been classified in the top 5 drugs that can produce depression. Another example, medications like alirocumab or evolocumab, which are used for regulate cholesterol levels, show high incidence of psychiatric adverse effects. 22% of them are psychiatric, and it's important because 25% of the cholesterol in our body is in our mind, is in our brain, and it's related to myelinization process. Another example are semaglutide, liraglutide, which are used to regulate use in patients with diabetes or overweight, like in our patients with psoriasis, for example. And it has been shown that although they present less number of adverse effects, they are very severe. They have been reported 9 suicides between 2021 and 2023. And to finish with examples, post-finasteride syndrome, we received last May a warning for the use of finasteride 1 milligram in patients with alopecia, and they suggest a strict control of the psychiatric previous status and the adverse effects. So, is inflammation always harmful for the central nervous system? Well, I published this article a few years ago when I hypothesized about the possibility that treatments, anti-inflammatory, anti-cytokine treatments, can act as antidepressive because of their anti-inflammatory mechanism. And perhaps this medication improve the mood in normal patients, and perhaps in patients with the previous status can produce a switch and make that these patients could have a mixed episode, and this can predispose to suicide. And two years later, Dr. Miola published this article where in part they explain this mechanism. It's interesting because they take 44 cases, they took patients who have received anti-TNF alpha, and these patients had adverse effects, mania in 97% of the cases. No one had a depression, and the interesting is that 93% of these patients didn't have previous psychiatric history. And perhaps the explanation could be related to the fact that TNF alpha is necessary in our brain. It's a modulator, and it's related to apoptosis, synapses, neurotransmitter regulation. So perhaps when we give this medication, the sudden decline of the levels of TNF alpha can modify the balance between inflammation and apoptosis. And it's interesting that lithium, which is the gold standard treatment for the bipolar disorder, has an anti-inflammatory mechanism of action. So, is it possible that we underdiagnosing depression and bipolar disorder? I think it's possible, but in my opinion, prospective studies, especially designed, are necessary. We should improve the patient selection. I think we should use standardized methods to selection patients. I think perhaps an in-person interview would be necessary. I think it's important shouldn't exclude patients with depression, because we are looking for suicidal behaviors, and we exclude patients with depression. And I think the follow-up of the correlation with psychiatric symptoms and the status of the inflammatory status could be interesting. So, probably medications do not directly cause depression, but can unmask pre-existing vulnerabilities. Thank you very much.